Okay, then let's move through some basic elements of glomerulonephritis. We're going to talk about some of the basics of presentation. I'm not going to go through this Venn diagram in a very deep way, but I'm going to let you study it and just orient you to this. We're going to go over some of the disease associations that are often predisposing factors or context in which glomerulonephritis occurs. And then we're going to talk about some of the complement patterns. And rather than make it rote memorization, my goal is to give you a sense for a predictable change in complements, okay, based on what you understand about the pathogenesis of that particular GN. So this Venn diagram is broken into hematuria without much proteinuria. So this is the hematuria circle, but it sits outside of the nephrotic or subnephrotic proteinuria. So these are primarily hematuria without much proteinuria. And early IgA nephropathy can do that. Early thin basement membrane and Alports can do that. And we can also have an early, let's say, class 2 lupus nephritis that does that. Okay, those would be examples of conditions that can do that. Here in this segment are proteinuric kidney diseases that may not have much hematuria, but are not nephrotic. So diabetes is a classic one, of course. The idiopathic nephrotic syndromes include FSGS, membranous, and minimal change disease. Those travel as a pack throughout this diagnostic this organization of diagnostic possibilities. You can have an amyloidosis, a lupus nephritis as well. Okay, so here we are in the nephrotic patient subset. Remember again, this three travels in a pack: minimal change, membranous, and FSGS. Certainly, you can see diabetes and amyloidosis presenting with nephrotic range proteinuria without much hematuria. Now, I'll make a few more distinctions and then I'm going to move on. Okay. Notice that even though many of you already have thought a lot about, or thought a significant amount about minimal change FSGS and membranous, and understand it to be a disease that presents with heavy proteinuria, but no hematuria. You might assume that these three do not present much with hematuria. But I want to highlight that these three are not rarely associated with hematuria as well. You absolutely can have hematuria with minimal change disease, FSGS, and membranous nephropathy. And so you can see that it is also in this segment of the Venn diagram, nephrotic range proteinuria with hematuria. Okay. Now, nephritic syndrome is certainly a subpopulation of patients that are often not nephrotic, okay, although they could be, but present with that accelerating hypertension, hematuria, and often declining GFR, okay? IgA nephropathy is another common condition. Its most common presentation that we see, okay, is IgA nephropathy with subnephrotic proteinuria and hematuria. Okay. I will then move on from there, okay, to some of these glomerular disease associations. Okay. Um, so let me take one step backwards. When I say, when you're making a diagnosis of GN, okay, one of my practice principles that I try to teach is don't just use the terms nephrotic and nephritic, because you'll end up tangling yourself in knots if you constrain yourself to only those two buckets. That's why I choose to present it in this way. Rather use the term nephrotic range proteinuria with no hematuria and preserved GFR, okay, and then start expanding out your differential. Or proteinuria, subnephrotic proteinuria with hematuria, and then start looking at this segment of the Venn diagram for your differential diagnosis. Occasionally, I'm going to have an overlapping nephritic and nephrotic. And so once again, if you're using these binary terms that you presume are mutually exclusive, you're going to twist yourself in knots. I would just say, accelerating hypertension, or I'll just call it nephritic or rapidly progressive GN, or accelerating hypertension with microhematuria and nephrotic range proteinuria. And then I'll focus on this segment of the diagnostic possibilities. Okay, so that's one way that I start to focus my differential diagnosis in a patient that sits before me. The other is I take stock of what are the other contexts that are going on with the patient. And so I start with this first, let's say, cut, where I'm narrowing down my differential diagnosis. And then I look at the context and I say, oh, this patient has, for instance, a ankylosing spondylitis. I know that ankylosing spondylitis has an association with IgA nephropathy. So this patient who's presenting with subnephrotic proteinuria and hematuria, as well as ankylosing spondylitis, this is the top of my differential, as opposed to invoking, an infection-associated GN, an Alport's, or an early ANCA-associated vasculitis. Okay, so that's the logic here. Hopefully you follow. Narrow it down without using only these two restrictive terms, nephrotic and nephritic, and then start looking at the context and start narrowing it down further. And unfortunately, there's no way around, just a bunch of memorization here, okay, of these associations. I give it to you in this table form so you can, look at it multiple times as you parse your clinical problems that you're solving day in and day out. And then eventually you're going to start owning these, okay? Let's go through a few. I'm not going to go through all of this in the interest of time. Of course, you know that amyloidosis has an association with paraproteinemia, as well as chronic inflammation, okay? Maybe some ones that you haven't thought much about are this ELECT2 amyloidosis, which is actually more common. It's described to be more common in our Hispanic population, okay? And then there's these more esoteric forms. I won't go through them individually. Fibrillary, and immunotactoid. These are somewhat esoteric kidney conditions. You'll see only a handful in a career. These have associations with paraproteinemias, CLL, lymphomas, and then these infectious diseases and autoimmune diseases. Okay? FSGS, let's take some time on this one because this one is fairly common. There are certain secondary forms of FSGS that are associated with the collapsing variant. Okay? HIV can be associated with collapsing FSGS, Hep C, Parvo, and then bisphosphonates are usually also associated with collapsing FSGS. And that's typically pamidronate, the most commonly associated one. We don't use much interferon in the present day of managing HCV, but heroin and interferon are also associated with a collapsing form of FSGS. Certainly, you must know by now that our population, Black race population, our U.S. population of Black race has a high prevalence of these risk alleles for progressive CKD, the so-called APOL1 risk allele. You need two of them to confer an increased risk of kidney disease. This confers an increased risk of hypertensive nephropathy, FSGS, and collapsing FSGS, okay? People have also shown associations with APOL1 risk alleles and worse prognosis in even lupus, okay? But that data is much weaker. What's solid is two risk alleles for APOL1 confer an increased risk of hypertensive nephropathy, FSGS, and collapsing FSGS. The risk of collapsing FSGS is increased quite significantly compared to the very low rates that are typical, okay? There's something like a 30-fold increase in risk of collapsing FSGS with two APOL1 risk alleles, okay? We'll talk more about that in our FSGS chapter. Obesity has an association. All right, now I have to say a few words. We'll talk about this more in when we talk about FSGS, but in broad strokes, FSGS is a wastebasket diagnosis that captures a lot of different things, sometimes associated with infections, sometimes associated with a circulating permeability factor, and then sometimes associated with what we call just conditions that cause adaptive FSGS or hyperfiltration. Okay. Obesity, hypertension, sickle cell nephropathy, reduced renal mass would be examples of that. There's genetic forms of FSGS as well. We'll talk about those in greater detail. IgA has associations with seronegative arthritis, celiac, inflammatory bowel disease, and HIV and cirrhosis. Okay. Membranous nephropathy, you can read here the associations. Primary membranous may have or often has measurable autoantibodies, the most common of which is PLA2 receptor antibodies, but we have another multiplicity of other causes of membranous nephropathy that are listed here. Lupus being one of the most common. Hepatitis B is associated as well. Some cancers are associated, and then some drugs. Minimal change disease. Hodgkin's has an association, as you can see, as does HIV, and then others. Okay, you can see I'm trying to intentionally move pretty fast here. Okay, notice again, this table summarizes the disease associations. That's how you narrow down the differential. If I have somebody who presents with, again, hematuria, accelerating hypertension, heavy proteinuria, as MPGN often does, and they also have Hep C, MPGN is going to be in the top of my differential diagnosis. Okay, we have pauciimmune small vessel vasculitis, the classic, the most common of which is MPA and GPA. Mustafa gave us a wonderful lecture about that yesterday. We also have EGPA, which is much less common, and then some drug-induced and RA-associated small vessel vasculitis. Alport's syndrome is generally associated with X-linked inheritance and can have eye and hearing effects as well. Okay? Questions about these disease associations? Okay. Then the last.
Dr. Sam, really quickly, for the secondary causes of these syndromes, do these tend to be like the other diseases are well established, or are these ever the initial like diagnosis of other disease, say like Hodgkin's disease? You find minimal change disease first and then end up finding the Hodgkin's after, or do they tend to have the other disease present for a while before presentation of their GN?
It's funny that you should say that specific example. There was a patient in our GN population who had a history of Hodgkin's disease in the past in remission, and then his first presentation of relapsed Hodgkin's disease was a presentation with minimal change disease, and then later found Hodgkin's. So in general, that's an interesting one, minimal change in Hodgkin's association. In general, well, hepatitis B is another one. People are typically asymptomatic and then present with, they can present with membranous nephropathy. In general, they have Hep B E antigenemia. So you know that is associated with a lot of viral replication. But you know that hepatitis B is typically asymptomatic until it presents with cirrhosis. HIV and its associations, I guess my answer is if you think that the condition can present with smoldering to minimal symptoms, right? Like advanced HIV can be relatively minimally symptomatic, and you just present with, you have low CD4 counts, you can present with the kidney disease as the presenting feature, right? But on the other hand, if you have, I don't know, what can I say here? The chronic infection, right, where you're having, you know, skin popping, right? And then you have abscesses all over your body that, you know, this patient has had abscesses for years before the amyloidosis is manifest. Okay, is that fair? It really,
Yep.
think of the associated disease and think of its course as you decide whether one may precede the other in terms of symptomatology. Okay? All right, let's move then to complement. Again, so what I'm trying to give you is the tools to say, you know, more than this patient needs a kidney biopsy. I don't know what's going on, but they need a kidney biopsy. I want you to be able to narrow down your differential diagnosis and give in your assessment and plan, this is what I think is most likely. Okay, so you do that by starting with these labels. Remember, use more than just nephrotic and nephritic, looking for other context, both in terms of diseases and drugs, okay? And then you look at complements to make some further, you know, stratification of your differential diagnosis. All right. Now, you would expect, you have to remember a little bit about complement, okay? And then I'll go to maybe the MPGN chapter to highlight some of this. Okay, this is a much simplified figure that summarized the complement cascade. All right. So you have a classical pathway of complement activation. Okay. And notice that that involves the binding of immunoglobulin G or M. Those are the ones that activate complement through the classical pathway. Okay. And then notice that once you get um, uh, further along in this classical pathway, you then converge at C3. C3 then associates with other complement proteins to form the membrane attack complex, which generally causes, you know, death of the organ of the bacteria, or, you know, injury to the host. Okay, and then you have this alternative pathway. You'll have to remember that C3 can spontaneously hydrolyze and start to just activate the membrane attack complex, or create the mature membrane attack complex. Okay? You have inhibitors of this spontaneous hydrolysis and unopposed um, cell lysis. And so I might have a mutation in complement factor H, a classic cause of atypical HUS, or um, uh, other forms of complement dysregulation. Okay, C3GN. I was searching my brain. Okay, C3 glomerulonephritis. Right, this can occur when I have a mutation in complement factor H. Right, that's a classic way that that can present. All right, so then let's intuit what we may find based on what we know about some of these conditions. Notice that IgA is not effective at activating complement, right? Through the classical pathway. IgG and IgM are, IgA is not. So my question then, as you think about this, in IgA nephropathy, you have circulating immune complexes. It's primarily IgA. You have some IgG in those immune complexes. You do have IgG, but it's mostly IgA. And those immune complexes then would not predictably consume C4. And so I should not see a depression of C4. I generally don't see C3 depression either. Okay. I do activate complement at the level of the tissue, but when measuring C3 in the periphery, I don't see any depression of C3. Okay. If I have C3GN, where I have a mutation in complement factor H, you'll notice that I should have a depressed C3. My C4 should be normal. Okay, and so both in atypical HUS and C3GN, You don't always, but you can certainly see C3 depression, C4s that are normal. Okay. What about lupus? Lupus is a condition in which I see IgG containing immune complexes that are circulating. Okay. And so in lupus, you would expect, in many cases, though not in all, to see depression of C4. And remember, if I'm consuming complement through the classical pathway, I would typically see C3 depression as well. Okay. So those are some of the things to understand as you're predicting what you're going to see in your complement patterns, okay, when you measure them out in the periphery. So let's go back to our summary of what we see. Okay. Again, if I can conceive of this condition being primarily through circulating immune complexes containing IgG or IgM, lupus being one of them, MPGN is a classic one. Naveen and I talked about this quite a bit during the weekend. So Naveen, if you'll recall, when you have mixed cryoglobulinemia, that's typically a combination of an IgM, which is your rheumatoid factor, and a polyclonal expansion of IgG. So MPGN often does have depression of C3 and C4, okay? Cryoglobulinemia is often a part of MPGN. We'll talk more about that when we talk about MPGN. And then when I have a chronic infection, a classic being bacterial endocarditis, that too might predictably generate immune complexes rich with IgG and IgM, and then therefore depress C3 and C4. Okay. When I see disproportionately depressed C3, again, I'm thinking about the alternative pathway. The classic ones are these C3 glomerulopathies. Okay. We'll talk about what that means, but C3 glomerulopathy basically captures these conditions. Okay. Dense deposit disease and C3GN are both disorders of alternative pathway complement regulation. Atypical HUS is as well. Okay. And notice again that atypical HUS, even though it's not a GN per se, it's a thrombotic microangiopathy, it can have a depressed C3. Okay. Interestingly, post-infectious or post-streptococcal GN often has primarily depressed C3, not C4. Okay. Post-streptococcal GN we do see in adults, but the most common infection-associated GN that we see is going to be in the context of a staphylococcal infection. In the adult population, staph is the most common cause of infection-associated GN. Okay, and then you can see depressed C3 in that scenario. Chronic infections, where I'm chronically stimulating the humeral arm, I tend to see both C3 and C4 depressed. These acute infections, I see primarily C3 depressed. In post-streptococcal GN, this is more reliable for a pattern that you might see. You absolutely can have a staphylococcal infection-associated GN with normal complements. Okay, so these are just clues. They are not diagnostic features. Okay? I'm going to say a few words about Cytoxan, and then let you read mostly about this, but I'll just make a few points. I think it's probably primed by Mustafa's journal club that he gave us yesterday, so I could be pretty brief. Okay, he told us a lot about this molecule or this drug. Okay, a couple of things that are useful to you clinically. All right. This is a fairly bioavailable drug, and so oral dosing is an effective means of delivery. And once again, oral cyclophosphamide is more potent an intervention than IV cyclophosphamide, simply because you get more total dose. When you're giving it daily over 3 to 6 months, you get more than you're getting if you're giving it in pulse IV dosing. Okay? This active metabolite acrolein is the problematic one that causes hemorrhagic cystitis. Okay, ifosfamide does that as well. Okay. This drug is eliminated in the urine. We say when you take your cyclophosphamide, take it in the morning, and so that it sits in your, or it doesn't sit in your bladder all night if you took the dose at night and then cause that irritation through acrolein, this metabolite. So take it in the morning with a glass of water or liquids so that you can urinate out that acrolein throughout the day. Okay. In rheumatologic diseases, again, IV dosing gives you less than half of what you're getting if you're giving it orally. In lupus, IV dosing appears to be equally efficacious to oral dosing. So even though you're giving less, the efficacy seems to be preserved. Ankylosing, Mustafa taught us that in a short-term randomized control or shorter-term randomized control trial, Cyclops, the remission was equivalent with IV versus oral. Remember, don't use the lupus protocol, though. You have to give it every 2 to 3 weeks if you're going to give it via the Cyclops protocol. But relapse rates are increased. Okay, so personally, I don't use IV cyclophosphamide for ankylosing. The typical dose for pulse IV dosing is 750 milligrams per meter squared. We give it over about an hour. Okay, it can be given even quicker if you'd like, but that's our protocol here. If you have advanced renal dysfunction, because this is renally cleared, then you need to reduce the dose. Okay, the same is true if you've got an elderly person. If you have an obese patient, I generally use the idealized body weight in order to prescribe it instead of just using their BSA and not correcting for the habitus. Okay, if they have resistant disease and you're not leukopenic, you can increase the dose even further than 750 milligrams per meter squared. I don't do that very often. I've probably done it once in one patient that I can recall. Okay. For oral dosing, Mustafa taught us 2 mg per kg is a standard dose. If you have reasonable GFR, you notice that you have to lower the dose because it is renally cleared. Okay. You can push the dose to 2.5 mg per kg as well. Okay. What are the adverse effects? Nausea is common, okay? It happens with the IV dosing. We give Zofran routinely. I would say about a third of the patients have a lot of nausea. I mean, to the point that they're vomiting multiple times. It typically doesn't happen the day of. It happens in day 2 and 3. What I do in that patient population who has that experience, I say, oh, I'm sorry that you had this with your first infusion. This time, take Phenergan starting the night of your infusion and just take it round the clock. I use Phenergan because I try to get them to sleep it off as well for about 2 days. And generally that gets them over this experience, which it can be pretty profound. 2 days of multiple episodes of vomiting is pretty traumatic. Okay. Infertility is the other main risk, okay? And it's pretty common if you're an older woman, okay? If you're over the age of 30 and you give cyclophosphamide, that's a pretty high risk of infertility, okay? And if you're younger, less than 20, it's about 15%. Now, these numbers, these infertility rates, are based on older data without routinely using Lupron, okay? We generally are using Lupron in women to put them in medical menopause. Ideally, you give it 2 weeks before the dose of cyclophosphamide. We don't do that. We basically just give it the day of the first infusion. We give a depot form, and it lasts 3 months, okay? But you may consider giving it separately 2 weeks before. If you recall, with that first dose of GnRH, you get ovulation, Okay, it's just with the sustained elevation in GnRH that you have suppression of ovulation. Okay, so ideally you give it 2 weeks before, but we don't do that. It's just too tedious. We just give it to them with the first dose of cyclophosphamide, and then we protect them through the other doses. Okay, you can consider banking sperm or ova. That's hard because in general, lupus has some association with estrogen, and giving the high doses of estrogen that may be required for the protocols for ovarian stimulation and recovery of eggs could theoretically precipitate a lupus flare. In general, we don't worry too much about the infertility in men, although there's theoretically a risk, and some have shown giving testosterone might help alleviate that. I've done that once, if I recall, but it's really not something we worry too much about. Okay, cystitis is the other risk to be aware of. Some people don't really pay attention to this. For instance, Ramesh, it's my understanding, he's obviously a very experienced nephrologist, doesn't worry too much about Mesna. He states, accurately that hemorrhagic cystitis is most commonly associated with high-dose ifosfamide infusions. Okay, we give much lower doses than are given in cancer therapy. Okay, the cyclophosphamide doses we give are quite small in comparison, and so the risk of hemorrhagic cystitis is minimal. To me, there's no downside, so I give it. In general, you mix it in the prehydration fluids that you're giving with that cyclophosphamide. I generally give Mesna in 1 liter, the cyclophosphamide in 250 cc's, and then I give an equivalent amount of Mesna as I give cyclophosphamide. Okay, if I'm giving 1,500 milligrams of cyclophosphamide, I'm giving 1,500 milligrams of Mesna. So milligrams per milligram. Okay, I've already talked about this oral dosing in the morning with liquid to avoid hemorrhagic cystitis in those taking oral cyclophosphamide. Okay, the cytopenias that you see are typically seen at 1 to 2 weeks. That's where the nadir happens. Okay, and then it recovers. I don't look for it. Okay, I don't routinely check a CBC at 1 to 2 weeks. To me, if your counts have recovered by the time I'm ready to give you the next dose, we're good to go. I don't want to be frightened by this nadir white count. So I just say, let's just check it before your next infusion. And if your white count has recovered, we're good to go for the next dose. Okay. And then, of course, you have cytopenias with oral dosing. You can follow those at 2 to 4 weeks as well. All right, here's the last thing that I think is most relevant as you're parsing your clinical care. Okay, this is really important. So I'll just slow down for just 1 second. Malignancy is the main thing that scares people. Okay, you would need to counsel about that. The infertility rates you'll counsel about. The malignancy is the other main thing you counsel about. You certainly talk about some hair loss and some skin discoloration, but malignancy, you got to slow down. Okay, the clear risk of malignancy happens when you give a cumulative dose of around 35 grams. Okay, this is based on a nationalized health system in one of the Scandinavian countries, I forget which, so that they can track cancer rates through a single health system, right? They don't have the complexity of multiple payers, right? And so in that retrospective analysis, this increased risk of cancer was seen at a cumulative dose of around 35 grams or more. Okay. Now, what is the typical dose we're giving with lupus? We're giving with lupus somewhere around, depending on the patient size, 750 milligram per meter squared is 1,300 or so, somewhere between 1,300 and 1,500 milligrams. Okay. So if we do the math, 6 doses, let's round it to 1,500, is 9 grams of cyclophosphamide. So you can go through 1 cycle, 2 cycles, 3 cycles before you're reaching these cumulative doses that are clearly associated with a detectable increased risk of cancer. Okay. The cancers that are most common are the leukemias and skin cancers. Bladder cancers are also increased in risk, okay, compared to the general population. You can also have non-cancerous myelodysplastic syndromes as well, aplastic anemia, for instance, etc. Okay? I haven't seen much hepatitis with cyclophosphamide, but it is a possibility. And the cardiomyopathy and pneumonitis are really with the BMT doses of these medicines, not with the doses we use.